Hello all, my name is Brianna McConnell, and for my final presentation for maternal and child health, I chose to focus on the topic of suicide in adolescents and teens. I chose to focus on this topic from the perspective of a public health educator. In discussing suicide among adolescents and teens, we must first define the problem. Suicide among teen and adolescent girls, specifically between the ages of 10 and 14, has nearly tripled within 15 years. This can be attributed to the recession, bullying, and social isolation. Some social determinants, which we will get into later, that factor into the problem of suicide among teen girls include lack of access to healthcare due to poverty and unemployment, bullying and the social struggles that come with bullying, and social isolation. I found within my research that suicide among teen girls was most prominent in the states of Ohio, Pennsylvania, and Michigan from 2004 to 2010. Again, in regards to the recession, approximately 15% of citizens in 2009 were uninsured, and 7.2% were unemployed. This creates a lack of access to mental health care, as well as health care overall. Bullying creates a feeling of withdrawn, which results in a feeling of helplessness, and social isolation. In regards to social isolation, large support systems in place result in a lower risk of suicide. In regards to teen and adolescent suicide, we can apply this issue to the social ecological model. The first level of the social ecological model is the individual level. At this level, it helps that teens know how to respond to a friend in an emotional crisis and know the warning signs of depression or suicide. What hinders this issue at the individual level is when teens do not know who or where to seek if they are having thoughts of suicide or if they withdraw themselves from friends. At the interpersonal level of the social ecological model, it helps if parents seek counselors, crisis centers or hotlines, or support from teachers if their children are experiencing suicidal thoughts or bullying and are playing an active role in their teen's life. What hinders at the interpersonal level is teens who are withdrawn from friends or experiencing bullying resulting in the feeling of helplessness or withdrawn from potential resources that could help them out with this issue. At the organizational level, it helps if schools implement training sessions for teachers on ways to effectively intervene with bullying. What may hinder at the organizational level is if the parental workplace does not provide insurance or mental health care to cover teens who are in need or in crisis. At the community level, it helps if there's social integration, including participation in churches, interest groups, and recreational activities, which leads to a lower chance of suicide. These activities do not even need to be related to the rate of suicide or decreasing suicide within the community, but general participation in social integration results in a lower chance, and just having that support system. What hinders at the community level is the exact opposite of social integration. Situations such as divorce, immigration, low church attendance, or small or low social integration. At the policy level, one policy that helps suicide among teens and adolescents is the National Suicide Prevention Hotline. This hotline provides free, confidential, and trained counselors in specific areas, including teen suicide. A policy that may hinder teen suicide has been the FDA's warning label requirement to post a warning on antidepressants that they could lead to depressive or suicidal thoughts in teens. This has led to doctors choosing to not prescribe antidepressants to teens in fear that this may occur. Some proposed interventions that I was able to research that may help the issue of suicide among teens and adolescents include the Sources of Strength program. This program is a universal suicide prevention program used primarily in schools, which is designed to promote strong sources of support and reduce suicide among vulnerable youth. This program utilizes elected peer leaders and teacher leaders, provides interactive 4-month training, and overall increases acceptability in seeking sources of support. This program can be used directly towards adolescents. As a health educator, I would be able to intervene as a staff and peer trainer to effectively promote discussions, presentations, and public service announcements regarding the dangers of suicide. I would also be able to conduct teacher trainings after school hours regarding how to conduct respectful and trusting conversations between adults and adolescents. Another intervention that I have found to be highly effective is a peer group approach to building life skills. This program is a school-based program which targets specifically youth between the ages of 14 and 19 years old who are at risk of substance abuse and emotional distress. This program utilizes peer support and parental support, crisis response training, and promotes safe and healthy activities among teens. To adapt this curriculum to my targeted population, I would eliminate the original proposed requirement that youth must be at risk as identified by having poor attendance and poor academics. As a health educator, I would first try to include adolescents at risk for bullying and self-harm, those who self-identify as having depressive thoughts, and then open up the enrollment to the program to anyone else who would want to participate to foster the maximum amount of social support within teens in schools and kind of get teens out of their usual peer groups and promote friendships among other peer groups. Another intervention that I have found to be effective in reducing teen suicide rates is the emergency room intervention for adolescent females. This program is targeted towards adolescent females who have attempted suicide and have arrived to the emergency room for care. It utilizes counseling and outpatient treatment, education and strategies for coping, and encourages adult and additional support. Although the role of a health educator is not very common in an emergency room, I would adapt this program to be used outside of the emergency room. As a health educator, I would conduct crisis support training within the home, school, or whatever comfortable setting. And my main focus would be to discuss issues that adolescents are dealing with that may lead to depressive thoughts or suicidal thoughts, such as sexual pressure, body image, bullying, substance abuse, and self-harm. This program would foster social support and relationships with teens and adults, and an accompanying adult would attend the counseling or education sessions. In order to evaluate these proposed interventions, my targeted goal for the Sources of Strength program would be that approximately 80% of adolescent students in this program will reach out to one adult in their life to seek conversation or advice. In collecting baseline data, I would use a survey which would include questions regarding students' thoughts on reaching out to both peers and adults and how they think about this issue to discuss issues that may lead to suicidal thoughts. I would then collect post-intervention data using the same survey. And in conducting the survey, the most important aspect to consider would definitely be confidentiality. Students must feel comfortable answering these difficult questions and would most likely be much more honest in their answers to these questions. To evaluate a peer group approach, my goal would be that schools will create a safe space where approximately 80% of students would seek out additional peer adult support when experiencing an emotional crisis. In order to collect baseline data, students and teachers would be surveyed again before the program, and the survey would ask both students and teachers to identify their comfortability level with seeking help during an emotional crisis within the school setting. I would collect post-intervention data the same way by a survey, and it would determine whether a safe and confidential place for students to express their thoughts would even be needed in order to avoid crisis situations within the school. Lastly, an intervention that I could utilize for the emergency room intervention would be would collect baseline data that would include girls who are brought to the ED for attempted suicide would be asked to identify an adult in their life to attend counseling sessions with. Again, since I would not be implementing this program in an emergency department, I would ask the same question in whatever setting that we would be conducting the session in. And after program implementation, the girls would be asked the same questions and answers would be recorded and compared to those answers that they answered previously to the intervention. Important aspects to consider would be connecting teen girls to the proper resources if they are estranged from their families, homeless, or without social support, and finding that support for them. Some challenges and barriers that would come with these interventions would definitely be school support, lacking the time, the resource, and curriculum adjustments that schools already have challenges with. Another challenge or barrier would be funding for these programs, which could be helped with applying for grants or conducting presentations to community partners who would be willing to donate. And lastly, a challenge would be really gaining community support and community buy-in. This would have to be resolved by hosting community events. Lastly, I would like to share the logic model that kind of ties my entire presentation together. Listed, I have all of my inputs, including that in order to decrease and kind of address the issue of teen suicide and adolescent suicide, school support would be needed, funding for curriculum materials and space would be needed, and general positive support from community members would be needed. Activities, again, as a wrap-up, would be my Sources of Strength program, Reconnecting Youth program, and the emergency room intervention, which would actually be any intervention, again, changed, kind of molded to address my students' needs as a health educator. The outputs from my programs would foster positive social support between teens and adults regarding suicide and the discourse and conversation of suicide, establish a safe place with support groups for teens, and establish crisis interventions between teens and accompanying adults after a suicide attempt. The outcomes from these programs is that schools would create a culture of support instead of isolation, teens would be actively seeking out discussion, and teen girls would have a crisis plan or person to reach out to. This entire impact would result in decreased suicide among teens and adolescents. I hope everyone has enjoyed my presentation and has learned a little bit something about the issue.